Hi, good afternoon, everybody, and welcome to our second Federal Community of Practice webinar for the year of 2023. My name is Carl Morneau, and I'm the Vice President for Client Success over our government division with GetWell. Today we have four healthcare systems that are actually going to be presenting some best practices. So this is going to be a really exciting webinar. And for the first time, we've actually invited one of our commercial partners to come and to celebrate some of the work that they're doing using GetWell Loop within their healthcare system. And so they will be closing us out today. But before we get started with the content, I wanted to go over just a couple of housekeeping tips for you all on how to actually navigate the GoToWebinar platform. And so you probably already noticed by default, everybody is muted once the webinar begins. If you would like to ask a question, just so we can keep this kind of professional a little bit, and not have a million people, trying to ask questions at the same time, we ask that you use the questions box located in your control panel to type in your question. We have allocated time at the end of each of the presentations where we will review all of the questions that are asked. And so feel free, that you don't have to ask the question during the presentation. You can actually wait anytime during the presentation. If a question were to pop into your mind, feel free to just use that to type the question in, and then we'll get to it either at the end of the session that's currently being presented or at the end of the webinar itself. And then finally, once the webinar completes, there's going to be a survey that's going to be asked for everybody once you close the GoToWebinar platform. Please take a few moments and complete this survey. This really helps us in planning future community of practice webinars, just to make sure that the content that we're presenting is relevant and helpful, with our future planning. So we want to make sure that this is beneficial for everybody that joins and listens in. So this is our agenda for today. So we have 4 healthcare systems that are going to be sharing with us some best practices around improving the veteran patient experience, improving education utilization through the volunteer program. And then also we're going to close out with LifeBridge's their successful implementation of GetWell Loop, which in the government space, we are so close to being able to launch this within our government client community. We're really excited. We've actually progressed now to 4 out of 5 in the in-process state within the FedRAMP space, and so we're still tracking an early August ATO award, which is going to allow us to be able to offer that solution, to our government partners. And so we're really excited. I know it's been a long time coming, and you're probably sick of hearing us talk about it, but we are so close. You can just about taste it now that we're almost there. All right, so without further ado, I'm going to go ahead and get started with Ms. Lisa Boyle. She is currently stationed at the Columbia VA Medical Center, but the project that she is going to be reviewing with us today is going to be a project that she initiated when she was working at the Charleston VA Medical Center. And so without further ado, Lisa, I will pass it over to you, and just let me know when you need me to advance the slides.
Okay, great. Thank you, Carl. Good afternoon, everyone, and hello from Columbia, South Carolina. My name is Lisa Boye, and today I'll be presenting to you the results of my doctoral project facilitated at the Ralph H. Johnson Charleston VA Healthcare System earlier this year on utilizing digital clinical nurse leader rounding to improve veteran experience, and this was a QI project. Next slide, please. I start with a project introduction. Nurse leaders must be innovative and develop strategies to address the dimensions that reflect personal patient engagement and improve those revenue streams within the organizations. Intentional rounding with the use of rounding tools such as a digital patient experience system and targeted questions by nursing leaders is documented throughout literature as having an overall effect on improving the quality of care and engagement. At this time, many organizations have clinical leaders in place who could be more useful in changing, if not improving, that patient experience. And utilizing a clinical nurse leader, or CNL, who typically does not carry a patient load to enhance customer service via rounding, this frees up management and bedside nursing for patient care, and it supports cohesiveness and quality improvement. And the results of leader rounding using these rounding tools are sustainable improvements in quality care and satisfaction. These have been shown to increase HCAHPS, SHEP, and Press-Ganey scoring. Next slide, please. Making sure a positive inpatient experience does not need to happen just in civilian hospitals. We all know that. Federal facilities such as the VA hospitals have the same needs akin to the civilian hospitals. The VHA, Department of Veterans Affairs, is the United States' most extensive integrated healthcare system. It provides comprehensive services to military or retired veterans who meet the eligibility requirements. And like its civilian counterparts, a reliable, valid assessment instrument must be used to assess quality. One hallmark survey that compares and measures this feedback is the SHEP survey that reflects an overall picture of the facility and the healthcare areas for improvement. And this survey really utilizes questions on specific topics to discharge patients. These patients are asked then to return the survey in a prepaid envelope. This, of course, is a timely process, and if returned, the surveys can be useful using the feedback scores. They can be used to target quality improvement efforts for enhancing patient experience and to identify practice variations. This process, like I said, is very time consuming, can take up to 8 weeks or more to get patient feedback, if any. This creates a noticeable gap in service recovery that should really begin at the bedside. For when the patient does actually return the survey, that service recovery has already been done. The Ralph H. Johnson Charleston VA healthcare system now employs the GetWell Network digital patient experience software that asks basically the same questions but allows on-the-spot customer service recovery based on answers to these questions. Currently completed by these patient advocates, sometimes by phone, sometimes by visitation. And if the patient has a complaint, then the complaint is passed on to the nurse manager for service recovery. But the goal is to have leaders rounding, actually connecting with the veteran to increase that patient experience score. CNLs at the facility were in a unique position to serve as that point of contact for service recovery, and they were able to access the digital software to make this happen easily. Next slide. The use of the digital patient engagement software can greatly benefit this type of rounding by the CNL, enabling patients to self-manage and equipping the CNL with ways to evaluate that veteran experience and deliver more personalized, on-the-spot customer service recovery. Case studies have found increased patient engagement with digital software by incorporating those questions in the system designed to have the most significant impact on the facility's goals for outcomes, which is, as we all know, the ultimate goal is to have great outcomes. So incorporating or embracing that new technology in rounding versus a manual method standardizes how nurse leaders can communicate not only with patients, but also with other departments, perhaps preventing poor patient experiences. Digital software like the GetWell Network can individualize those questions based on a unit's performance, enabling that unit to focus on areas that may be lacking, so leaders can look at individual units to see the scores and form projects or interventions to increase those scores. Next slide. This QI project focused on utilizing a combination of that CNL and the GetWell Network to try to increase the overall scores on the medical surgical unit called 4B North within the facility. The implementation included the CNL receiving an email message from the digital experience system, notifying them that a veteran has responded to one of the questions and provided feedback on whether the veteran wanted to be contacted about their response. If the answer was yes, the CNL rounded with the veteran to determine any issues or concerning using a rounding log. Intermittently, the system also asked other questions, and if these questions were answered negatively, the system asked if they wanted to be contacted regarding their answer. So if they answered no, the system generated an email to an advocate who generally responds via phone to support customer service or issues, making the experience more personal for the patient. The system can then place a numerical score on that patient experience based on those responses. This program supports a Leader Rounding Plus program currently not implemented at the host facility. So the project focused on 2 questions with staff communication. Question number 1 was, are your nurses listening to you and answering your questions? And question number 2 was, when you need help, does your care team come quickly? Next slide. So to estimate an adequate sample size before the project, a power analysis was conducted using a significant level of 0.05, a power of 0.8, and an effect size of 0.5 with a 1-to-1 ratio between those groups, meaning I needed a minimum sample of 102 with equal groups of 51. So once this data was collected, a chi-square test of the response was used. Since this project dealt with questions with yes and no answers, the variable was not a ratio level, but a nominal or categorical level variable. So a between group analysis of those nominal level variables, both independent and dependent, was analyzed using that chi-square test. An informed consent was not needed. Next slide. The digital patient experience system generates a quarterly or as requested report that gives the patient experience or PXP score overall scorecard per unit. Those PXP survey questions align with Press-Ganey type SHIP themes and give a real-time snapshot of hotspots on each unit to include the project unit 4B North. This report was queued for 8 weeks pre and post and then compared. Next slide. An 8-week baseline was reviewed prior to implementation from November 25th, 2022 to January 23rd, 2023. During this length of time, the overall numerical score recorded within the GetWell network was a score of 8.6, as you can see at the bottom left. The overall scores takes into consideration all the measurable areas within the PXP scorecard to include staff communication, that's your nurse communication and staff responsiveness, and these were the 2 areas of focus within the QI project. Nurse communication, as you can see, scored a 9.3 and staff responsiveness was scored at 8.6. This pre-data overall score represented the score to beat within the implementation. Next slide. The project implementation occurred January 23rd, 2023 through March 13th, 2023, a total of 8 weeks. 2 CNLs were trained on the GetWell Network software and were added to the GetWell Network to receive email notification for the system for negative responses or if the veteran asked to have someone address an issue. The CNLs responded to the email alerts Monday through Friday when on tour and followed up on Mondays for emails generated over the weekends. And the CNLs rounded with the veteran using a rounding log, re-asking the 2 project questions and also offering service recovery at the bedside for any issues. Next slide. The CNLs completed a Microsoft Excel document with a rounding tool based on the alert in the email prompting them to respond to the patient room and focused on the 2 highlighted questions. And as you can see on the rounding tool, they did service recovery and they asked about noise, food and pain, and need for assistance. Next slide. Seen here is the bar chart for nurse communication, which was question 1 for the pre and post implementation. Looking at this chart, you will notice that a total of 120 patients completed question 1 provided on nurse communication. 69 completed the question in the baseline data or the pre-data before the rounding project began, and 51 answered after the implementation of the project. The patients were asked to answer yes or no, and these responses were collected and compared. 5 out of 69 patients, which equals 7%, answered no to the question in the pre-implementation data. Only 2 out of the 51, that's 4% of patients, answered no in the post-implementation data, representing a drop of 3% in the no type answers. Next slide. Really, no statistical difference was measured between those 2 frequencies, although 3 fewer patients answered no after the implementation of the digital rounding. Since one group really had less than 5 patients answering no, I did a Fisher's exact test, which was reported, and it's a more vigorous or rigorous statistical significance for small samples. It was also not significant with a p-level of 0.362. However, the figure does show clinically significant decreases of the 3 patients indicating no on the question, representing a 3% drop in the no scores. And of note, the sample really had more patients in the pre-implementation group than in the post-implementation group, resulting in unequal numbers of frequencies being compared. Next slide. This is the bar chart for question 2 on staff responsiveness. A total of 115 patients completed the question provided on staff responsiveness. When you need help, does your care team respond quickly? 65 completed the questions in the pre-data and 50 answered after the implementation. The patients were asked to answer yes or no, and these responses were collected and compared. 9 out of 65 patients, or 14%, answered no in the pre-implementation data. Only 1 out of 50, representing 2% of patients, answered no in the post-implementation data. Next slide. The outcome for question 2 was that 8 fewer patients answered no after the implementation of the rounding. As in question 1, because one group had less than 5 patients answering no, the Fisher's test was done. It was significant with a p-level of 0.041. And the outcome was that the data was both statistically and clinically significant for this question, representing a 12% drop in those no scores. Next slide. The GetWell network post data also correlates to the project findings as well. As you can see here, the overall patient experience perception score for 4B North increased from an 8.6 to a 9.1. While I know that this is a composite score for all the elements of the scorecard as shown, it is significant really to note that those other elements increased overall as well. For example, hospital environment score went from 8.9 in the preceding 8 weeks to a 9.5 for the project duration. Other areas that increased were the scoring in quiet at night. The 2 project questions scores also increased. Question 1 increased from a 9.3 to a 9.7, and question 2 on staff responsiveness increased incredibly from an 8.6 to a 9.8. Next slide. You can also see that GetWell Network reports an increase in the nurse communication PXB score from January to February from 8.7 to 9.4. Next slide. And the percentage of neutral or negative nurse communication responses decreased overall from January to February 2023 on 4B North from 11.9% to 2.3% during the project period. Next slide. So what does this really mean for nursing and for the facility? Well, patient experience has really become a significant factor in patient-centered delivery of healthcare, prompting those leaders to take strides in improving the experience. So although there was not a statistically significant difference in nurse communication, it is possible the intervention or this project provided veterans with a more realistic expectation of the nurse and changed the veteran perception of the nurse-veteran communication values. The improvement in staff responsiveness only serves to prove that the digital CNL rounding made veterans feel like their needs were being met in a timelier manner. The true value really of the findings to nurse leaders is what can be achieved through purposeful, real-time, question-driven digital rounding and veteran experience compared to the reactive practice of waiting for surveys to return after discharge from the facility. The literature really suggests as advanced quality of care is provided by motivated staff, leading to a lesser number of adverse outcomes and prevention of readmissions by using this rounding. A satisfied patient, of course, will more likely participate in their own care and maintain goals made by their healthcare provider. My goal for this project was to improve veteran experience utilizing the CNLs and the digital patient experience software in unison. The fact of the matter is that by utilizing the combination of the CNL rounding and the software, the experience was obviously enhanced, giving credence to the recommendation to the facility to use digital rounding software and utilizing nursing leaders to enable not only the veteran to have a say in their plan of care, but to perform service recovery to those veterans before they leave the facility. Next slide. The project findings were being statistically and clinically significant, provide new knowledge, and support previous findings found in literature. And the impact of this QI project was improvement. The results for both rounding questions were either statistically significant or clinically significant, and the results changed in the direction that I expected, resulting in a clinically significant finding. Not only was there statistical improvement in staff responsiveness, but the results were clinically significant, making the use of digital leader rounding worth the investment should the facility continue the rounding or choose a digital rounding program. Next slide. The QI project effectively impacts the veteran experience by utilizing digital CNL rounding, so the nursing profession should learn to adapt for a more digital future. CNL participants and veterans will continue to require ongoing support and feedback for adherence for long-term plan caring to sustain that rounding. Any future applications of the project are possible in an inpatient setting and really should focus on a longer project time frame and use of the already patented GetWell Network Rounds Plus software. The facility should continue adhering to consistent digital leader rounding, utilizing the CNL as a change agent to optimize the veteran experience. And continued support for using digital rounding software should be generated, throwing away paper rounding surveys in an effort to track all of this digitally. Digital technologies really may be viewed as a distraction from, or really an unwelcome intrusion into the hands-on caring role and the therapeutic relationships that nurses have with patients and families. This incompatibility with traditional nursing ideals such as compassionate care may explain why some nurses are reluctant to adopt digital approaches to healthcare. A project to maintain therapeutic relationships while using advancing technology really is warranted. And finally, we must urgently create educational opportunities at undergraduate and graduate levels for informatics, digital health, co-design, implementation science, and data science. And these should include opportunities to work and learn with computing, engineering, and interdisciplinary colleagues. For instance, nurses will need practitioners who understand how to use data science to inform the creation of nursing knowledge to support the practice. These nurses will also need savviness and courage to lead the development of these new models of patient care enabled by these digital technologies. Next slide. So in summary, the purpose and overall goal of this project was improvement of veteran experience as evidenced by the addition of CNL rounding prompted by the digital patient experience software. Pre-implementation data and project data were analyzed using a between-group comparison with assessment of veterans' rating of nurse communications and staff responsiveness. Nurse communication was found to be clinically, but not statistically significant, showing no statistical difference was measured, although 3 fewer patients answered no after the implementation. But the data collected on staff responsiveness showed clinical and statistical significance, noting a decrease in the number of patients who answered no to the question on whether the care team responded quickly. These findings add to the body of knowledge on the use of digital leader rounding to support or increase veteran experience. Next slide. That concludes my presentation. I want to thank the GetWell Network and its representatives for allowing me to share the results of this project during this Federal Community of Practice meeting, and to this group. I'd like to really recognize 3 individuals who played key roles in the project's success. First, I'd like to thank Octavia Lawston and Megan Wrench, who really were the change agents who rounded daily and kept this project on track. They should be recognized for their commitment to our veterans and their outcomes. Also, I'd like to say a big thank you to Dennis Schumann, Client Service Manager for Charleston, whose expertise with the GetWell Network system helped provide me with all the statistical analysis I needed. Thanks again, Dennis, Octavia, and Megan. Are there any questions for the group at this time?
Thank you very much, Bitsy. I am looking at the panel and I don't see any questions. For my other panelists, do you see any that I don't see by any chance?
I don't see any, Carl.
There aren't any that I'm seeing.
Great.
Okay.
Well, thank you.
Perfect. So if any do pop up, Bitsy, we'll go ahead and ask them at the end. Once
Sounds good.
They're complete. So thank you very much.
Thank you so much. And I am Hannah Fugusha Griffith. I'm the Client Success Manager for James A. Haley. I'm here with Ellen Tolson, our volunteer specialist. And both James A. Haley and the VA for New Jersey, we've both been working on GetWell volunteer programs. So we're going to talk to you about how we created those programs and exactly what we've done to implement it. So I'm going to give it over to Ellen.
Thank you so much, Hannah. And thank you guys, and good afternoon to everyone. This is me with my pre-pandemic hair, and I just wanted to include a slide that had my contact information. If there is anything that, any questions that you have, you can always contact me later, or you could have your voluntary service specialist contact me as well if you have any questions. But we'll go on to the next slide, which talks a little bit about our program inspiration. One of the nice things about being a VA employee is that there are other medical centers out there with more of me in other areas all around the country. And it was a volunteer specialist at Baltimore, when I was speaking to her about something totally different, who said that they have volunteers who help with their GetWell network. So that was kind of what planted the seed here for Hannah and I to see about getting volunteers here at James A. Haley. And what we were really looking for is some way to help our nurses out. We have the best nurses in the world here at James A. Haley, but they do a lot of things that are not necessarily clinical nursing. Things that help out the veterans, certainly, including helping out with GetWell Network and teaching GetWell Network to our veterans. So that they can get that good patient education information. But sometimes with some of our veterans, that takes a little bit longer, and we certainly don't want any of the clinical care to suffer. So we wanted to see how we could help out the nurses. That was one of our inspirations for looking for volunteers. So Hannah and I went to our steering committee and see if we could get some volunteers to help out with GetWell Network teaching. My background is actually as a dietitian. I started as a dietitian with the VA, and so I had a little familiarity with GetWell Network and the meals ordering program, and I could tell from that point that not all of our veterans were even able to order their meals or use the GetWell Network. So that was also kind of in the back of my mind. We have a little mention, a little shout out to our New Jersey folks who are coming up shortly, because when we started this program, we were just kind of going around and seeing how we could help folks learn a little bit more about the GetWell Network, have the volunteer teach the veterans a little bit more about the GetWell Network. But it wasn't until our New Jersey colleagues helped us with the information about rounding that we were able to get a little bit more work done with the veterans. So we'll go on to the next slide and talk a little bit about how our program started. So as I said, we met with our steering committee, and we came up with a volunteer assignment guide that you'll see shortly. This is a almost like a little position description, you can call it, for volunteers in any assignment throughout the VA. And VAs nationwide use pretty much the same form, so I've seen anyway. We also, Hannah was wonderful and created some training information for our volunteer that we went through with her before she went up to the floors. We did have a volunteer in mind who was already onboarded. And if you do think that having volunteers would help out with your GetWell network teaching, it is really great for college students. We are right up next to the University of South Florida. They're just across the street from us. We get a lot of college student volunteers, college students who are thinking about maybe applying for med school. So they're wonderful to work one-on-one with the veterans. So we already had somebody onboarded, but there's a whole onboarding process for volunteers that you can talk to your volunteer specialists about. And then for our volunteer that started, we did several walkthroughs with her. As I said, I'm a dietitian by training, so I felt very comfortable going into patient rooms. And so I started with her going into some patient rooms, pointing out things like who the nurse manager is on the ward and who the charge nurses are, so that she could have somebody to talk to in every ward, so introducing her around. But also our volunteers do not go into isolation rooms. So I was able to point out the isolation signage that is used so that she would know not to go into any isolation rooms. She also then did several walkthroughs with Hannah to learn about the different kind of GetWell network equipment that we use. And we can go on to the next slide. I think it shows that assignment guide. Actually, it doesn't, but that's okay. The link in that previous slide will let you get to the assignment guide. So initially, our volunteer was going around and asking the veterans if they felt comfortable using the GetWell network and showing them how to use the GetWell network, but she wasn't getting generating a lot of interest in her helping. And it wasn't until we worked with New Jersey, and New Jersey folks shared their survey that they do. We tweaked it a little bit, asking in particular about education videos, and but that was when our volunteer was able to kind of have a little bit more scripting for her questions, that we noticed improvement in the veterans getting the information. Next slide. And so what we did notice is our program started kind of mid-February going around, and we have a baseline of about anywhere from 20 to 25% of our patients getting some education completed. But once we got going with our volunteer going around, we could see an improvement in the percentage of patients getting some of their education that was assigned to them completed. So we could see some nice improvement in veterans getting the education that the doctors had ordered for them. Next slide. The other thing that we notice is not as quantitative, but just more qualitative. And I love the middle quote, because that was really what we really wanted to do, is help the nurses. And so that middle quote where the nurse says that she loves to see the volunteer and would like to see her rounding every day, and that it re-engages the veteran, and it does take the workload off of us. So I love that quote. Of course, I love the quotes from the veterans too, saying that they appreciate the added assistance in getting the educational videos shown, and there's that meal ordering that does my dietitian heart good. So next slide. So I'm going to turn it over to our New Jersey folks, and they can tell you how they utilize their volunteer.
Perfect. Thank you, Ellen. As Ellen mentioned, VA New Jersey healthcare system also started a very similar program with their volunteers. With us today from VA New Jersey at East Orange, we have patient relations specialist Selena Balecha and also Mildred Padilla-Morales, who is a Veterans Health Education Coordinator. I'm going to turn it over to Mildred to give you the background of how this program was developed.
Hi, like she introduced me, I'm a registered nurse, and I was a nurse manager for 34 years. Oh, maybe I shouldn't say years, but I was really young when I started. But anyway, but I'm proud of one of the things that I did notice now that I'm a veterans health educator, and we always had the medication list, which was really important, and I appreciate it because if the veterans get to see what meds, if there's something missing, they were able to tell us or tell the doctor. And we've gotten a few issues with this, and which we were able to fix and explain to the patient, and also explain to the doctor that the patient was on these medications that were not listed. So we were able to at least find a solution to the issue. But it raised a lot of questions, and one of the things as a veteran VHEC that I am, and I appreciate it, was that I would call up the patients to find out and talk to them to see if they know why they're taking the medications, what names of the medications they're on. You would be surprised how a lot of them just describe the medication by color. So that's why I like the fact that we do have that list. We could start them while they're inpatient, and especially before they're home, that they know at least what medication they're taking and why they're taking the medication. And trust me when I tell you, I had one patient take all his pills at one given, talking about beta blockers, blood pressure and everything. So it was good that I made the phone call, we straightened everything out, even though he was told. He felt it was easier if I take all the meds at once. So I had a lot of sessions with him, and I still get to see him. He knows and understands now why he was feeling the way he was feeling, because he took it upon himself taking it all at once. But this made a big difference, seeing the list and preparing them for their discharge. Thank you.
Next slide. That's our contact information. If anyone has any questions and would like to reach out to us, please feel free to reach out to us via email. Next slide. And as Mildred described, basically she transitioning from a nurse manager to the VHEC, the Veterans Health Education Coordinator, she did realize there was a need for us to point out the medication list. So we developed a form for Rounds Plus. We requested a volunteer, and you can go to the next slide. So you could see the form that we developed. It basically has 5 main questions. Does the veteran know how to view their medication sheets? Does the veteran complete the assigned education? Does the veteran have any questions? Did you show the veteran how to complete their education and view their medication list? And did you explain the importance of this? The Rounds Plus form was developed in a format in where we are prompting the volunteer. This was done purposely so that it's easy for the volunteer to follow. Our volunteer was savvy using the GetWell system and the iPad to round with. However, we did need to review speaking with the veterans openly and formally on the importance of this visit. She had to get comfortable with interrupting the patients, requesting to show them the system, asking them the brief questions, and sharing how beneficial the GetWell system is for them. The volunteer was not given a large commitment. We asked her to set a goal of meeting at least 5 patients per unit, and there were 3 main units. Once rounding became easier to her, she increased the number of veterans she visited during her volunteer hours, which are from 10 a.m. through 2 p.m. So she does start after they have their breakfast. She takes her lunch break at the same time they take their lunch break, and then she starts again in the afternoon and finishes. So she can complete over 20 forms during that one volunteer day that she commits to us. Next slide.
Thank you, Selena. In the next several slides, I'm going to review the outcomes in education and medication teaching utilization since the start of this program. We started this program in September of 2022, and since then we have seen a steady increase in personalized education utilization. From fiscal year Q4 to fiscal year 23 Q1, there has been a 20% increase in the number of patients with personalized education completed. Next slide, please. There's also a similar trend with medication teaching. Between fiscal year 22 Q4 and fiscal year 23 Q1, we have seen a 31% increase in the number of medication sheets viewed. Next slide. Lastly, you can see the correlation between the number of rounds plus forms completed and the percentage of patients that completed their personalized education. As the number of rounds plus forms completed increased, the percentage of veterans that completed their personalized education increased as well. So in summary, to assist with medication teaching and education utilization, lean on your volunteers by showing them how to complete rounds plus forms and show them how they can impact the veterans to complete their education and view their medication. This program can help take some of the non-clinical tasks off of the nurses as well as educating your veterans. Thank you very much. And I think now I'm going to turn it over to LifeBridge Health.
Yeah, before we go ahead and do that real quick, I don't see any questions in the chat box. And so if any questions do arise, we'll go ahead and get them at the end. But thank you very much for our VHA partners for your two presentations today. It was very great information. I'm really impressed with the increase in utilization that we're seeing, in VA New Jersey, as well as what we're seeing down at the Tampa VA. And it's really incredible work, and it's a true testament to the work that you're all doing, boots on the ground. And so thank you very much. So now we're going to go ahead and transition over to our partners with LifeBridge. And so I'd like to hand it over to whoever's going to take the lead from LifeBridge for your presentation.
Yeah, thanks. Carl, go ahead and go to the next slide, and I'll ask my colleagues to just go ahead and quickly flip on their, go to the next slide there, Carl. Flip on your webcams and introduce yourself. We'll start with Scott.
Good afternoon. I'm Scott Savage. I am the Director of Digital Consumer Experience here at LifeBridge.
Good afternoon. Hello, everyone. Will McKnight here. I'm the Analyst of the Digital Consumer Applications.
Hi, I'm Sharon Spencer-Kable. I'm the Director of Clinical Informatics and Education.
And I'm Adam Beck. I'm a Director in our Innovation Department here at LifeBridge Health, work at the enterprise level. And we don't have our contact information kind of listed here, but the GetWell team has our contact information. We are very appreciative of being invited to present to you all. I know you, and hearing that you guys are about ready to kick off with Loop. We have worked a lot with Loop over the past, I guess, 5+ years, and even a little bit before that, and got a lot of experience, and we're here for you. So if you have any questions or concerns, and you want to run those by us at any point in time after this presentation, please don't hesitate to reach out to Carl or others from GetWell, get our contact information. We're more than happy to hop on a call with you all. So first, go ahead and go to the next slide here, Carl. For those of you who may not know about LifeBridge Health, we are a 5-hospital health system based in Maryland. We primarily serve Western Baltimore City, Western Baltimore County, and out into Western Maryland itself. And you can see here that while we are a 5-hospital system, we are a health system, and we have a significant breadth of care being delivered out in our community. So we're not just hospitals, we've got the full spectrum, everything from urgent care to ambulance to post-acute care and much between. Go ahead and go to the next slide. So I'm going to kick off with a little bit of a history about GetWell Loop and how we have grown GetWell Loop up to this point. I'll hand it off to Will afterwards. He'll talk about where we've kind of created an enterprise foundation for supporting Loop going forward. And then Sharon and Scott are going to follow up with that and talk about how we're fitting in Loop with our overall IS ecosystem and what we look to do with Loop in the future. So go ahead and go to the next slide. So Loop started by our orthopedic department when actually wasn't owned at that time by GetWell. It was actually an independent company called Health Loop. This is way back in 2015. The orthopedic department was heavily involved with doing post-discharge or post-procedure follow-up with their patients, and they wanted a way to scale that better and automate it, and also create a digital mechanism for communicating with the patients, not only post-operatively, but also pre-operatively. A lot of that was being done at that time, but in not so much of a HIPAA compliant fashion. You can imagine some of the emails and some of the texts that may have been occurring without a nice, secured platform that Loop provided. So they went out, they found Loop, and they kicked it off, put it in place, and it was a tremendous success for their operation. The organization looked at it and realized we have an opportunity here to leverage this for some of the activity that we're doing across all of our hospitals, that being post-discharge phone calls. Go ahead and go to the next slide here. So I don't know if you all are in the process of, or have been doing this for a while or have done in the past, but we were trying to make an attempt to have staff reach out and contact our patients by phone after they've either been discharged from our hospital or after their visit to the ED, in an effort to ensure that they got off on a good foot and they were being cared for and they didn't have any concerns, and potentially revisit our ED or revisit our hospital setting. So we looked at what orthopedics did and said, you know what, I think we can actually take this, make some changes, do some iteration here, and create a tool to actually digitize that post-discharge follow-up process. And that's what we did. We actually built a very nice care plan inside of Loop and went big bang in 2018 at all three of our EDs in our main hospitals, that being Cara Hospital, Sinai Hospital, and Northwest, both for ED patients and also for our inpatients. It doesn't reflect here for inpatients, but we did it for inpatients as well. Go to the next slide. So right out of the gate, at that point, we were informing patients as much as possible during their visit, letting them know that they may receive an email or text when they return home. And we were allowing GetWell to do its thing and send out that text and send out that email. And we got 25% of patients not only just opening the email, but actually going through, clicking on that email, and activating and setting up their account inside a Loop. And that 25% stuck, in fact, even increased as we went through and our staff became more and more engaged on this. You can see how many, just in that first year, we had over 5,600 patients activate their account. And they weren't just activating their account and setting up their account. They were going through and checking in and letting us know how they were doing. So go to the next slide. And so through that process and then going through and completing the surveys in there and doing the check-ins, and we also opened it up for free text as well. We got over 2,300 alerts triggered for issues relating to discharge instructions. A big one, this is in the ED side here. On ED side, we saw a big issue with prescription refill requests and obviously follow-up appointments being a big one as well. On the inpatient side, if I showed this graph, it would be a little bit of a different picture, more so on the discharge instructions and diagnosis treatment plan, less so on the follow-up appointments. And then prescription refills being a big one kind of across the board. But a lot of engaged patients on the platform. Go ahead and go to the next slide. And what that resulted in, because we went back and we studied it in very, very similar fashion from a clinical perspective to what Lisa kind of described in her earlier presentation going through and doing some statistical analysis to say, all right, we see patients are engaged, they're checking in with us. How much of an impact is this might be having with our 30-day revisit rate for patients coming back into the ED? And we saw a significant finding that those individual patients that were leveraging Loop, they are following up with us through that platform at a much lower revisit rate than those individuals that weren't. And it didn't just stop at the clinical side of things. Patients were indicating they were very satisfied with the GetWell Loop platform. We tethered it where we could to our Google star ratings on our, inside of Google itself. So if somebody searched for the Northwest ED and inside of Google and brought it up, when we started out, they had like a 1.7 star rating. It was pretty rough. And so we went in and we set it up. We were saying we got a lot more engaged people that are having a very good experience. We're just getting a bunch, only those people that are having a rough experience or want to complain actually posting a star rating. We actually boosted that star rating considerably once we got those patients that were having a good experience to let us know they're having a good experience on Google in the rankings. Go to the next slide. So what made this a success? Measuring those positive outcomes and going back and reviewing it and seeing what the result of doing this type of work was really helped lead to not only the leadership buy-in and getting behind Loop and wanting to further this forward, but also the staff buy-in. We also made sure when we set this up that we didn't put hardly any, if any at all, additional burden on the front end staff. We wanted them to just make patients aware that we have the platform in place. We did not want those individual staff members to have to manually enroll patients. So we automated the enrollment using the ADT feed. We also didn't want any of that activity coming back to the staff post-discharge unless it needed to. So we were fortunate enough, we had a digital contact center already kind of initiated that we were able to leverage so that all of those alerts and comments and activity that our patients were reporting through the Loop platform were being handled by that team. GetWell was a great vendor. The Loop team was really, really good to work with. And they did a lot of iterations on the platform to make it work and work with not only how we were enrolling the patients for ADT feed, but also how we were handling the activity across our digital contact center. And then obviously continuous iteration. And you can imagine when COVID hit, we had to iterate quite a bit and adjust our loops accordingly, and then and constantly add in new content. And then also create additional loops for specific conditions, things like labor and delivery and other chronic care conditions. The next slide. So all of this work we did in 2018 and 2019, it really set the foundation for us, and you could see how many patients we actually have leveraging and utilizing GetWell Loop across our organization. It's been growing every year, and we will see, I'm sure we're going to see it continuously to continue to grow. Some of this actually has to do, we've taken a quick look at things recently, but some of it has to do with the impact of COVID. A lot more engaged patients on a digital platform after going through the COVID experience and leveraging telehealth. So with that, I'll turn it over to Will to continue on.
Thank you, Adam. Next slide, please. Yes, so I'm going to talk to you about our governance approach and our EHR integration here. Next slide, please. So at LifeBridge, our governance approach is governed by an IS, Information Services Organization, is socialized throughout acute and ambulatory service specialties, service lines, and individual providers and champions. We meet with our stakeholders on a regular bi-weekly, monthly, and quarterly basis with our internal stakeholders, executives, and GetWell representatives. I must say that we work really closely with the GetWell team throughout each process that we're working on, whatever we need. The GetWell team has worked really well with us here. We take a look at metrics and trend data, and that data is reported out on a regular basis, on a monthly basis to our stakeholders, so they can keep a close track on numbers throughout their particular departments. This helps them out quite a bit so they can see where they're doing well and other areas for improvement. So that helps them out quite a bit. And those reports are pulled directly from GetWell, and that information is readily available there. We also have new loop care plans that are introduced through a combination of internal education, stakeholder, word of mouth, regular updates from GetWell about new care plans and creative use of existing care plans. Next slide, please. So the EHR integrations here is with through the Smart app. We have a convenient Cerner power chart scheduling interface for providers to assign and monitor loops directly within Cerner. This helps our nursing staff tremendously when they're actually looking in and scheduling, having the opportunity to schedule patients on a loop directly within Cerner. Patient auto-enrollment scripts based on dynamic care events, ED and general discharge loops, pre and post loops, and chronic care loops. So patients are auto-enrolled on a loop through that Smart app that I just spoke about, and they're able to be placed on a loop in an automated fashion, which really helps out our staff as well. So there's not a manual process there. So that really helps them tremendously and takes a bit of a burden off of them having to manually enroll patients there within GetWell Loop. And with that, I'm going to finish off there and pass it over to Sharon. And Sharon is going to talk about the integrations into the larger GetWell network system. Sharon?
Thanks, Will. Next slide, please. We do have GetWell Inpatient. We've had it at our facilities for some time now, and with the integration that we have, or the coordination with the GetWell products with GetWell Loop, within GetWell Inpatient, what we have is called a loop enrollment pathway, and that pathway allows the patient to validate their cell phone number and their email address, so that if it is wrong, maybe someone mistyped it, or it's not the right one, or they changed, they can enter it in their experience while they are an inpatient in the facility, in the hospital. And then what that does is go back and updates GetWell for GetWell Loop, so that they can get the right invites at the right times at the right addresses. So with that piece of integration, we are using that. And the other thing that we are utilizing is what we call BYOD, is bring your own device. There is an app for an inpatient stay that they can use. It's called GetWell Anywhere, and it's a My Stay, but there's also a second tab now that they have in this app that they can download from either the App Store or the Play Store, and it has My Loop. And they can utilize, once discharged and they can activate their loop, they can use this same app that they used while they were an inpatient, potentially using the loop part of the app. And that way it's kind of all integrated in one space. Another good thing about the loop with the integrations with GetWell Networks is that if they are ordered education while an inpatient, and we order it through Cerner, some of it's auto ordered through GetWell Network, but from an inpatient standpoint, the nurse or the respiratory therapist or even the provider, we have it integrated in some of their workflows within Cerner, can order these educational videos, and they come into the inpatient. And let's say the patient might be too sick or doesn't have the bandwidth at the time to want to watch the videos. As long as the loop is active, it is linked to those videos during that inpatient stay. So if the patient watched it or didn't watch it during their inpatient stay, they would have that ability post-discharge through the loop to be able to review those inpatient videos. So there's lots of times good for follow-up, but also for viewing them for the first time. So with those pieces, those are some of the integration pieces that we have between the GetWell inpatient product and the BYOD or GetWell Anywhere. So with that, next slide, please. I'm going to turn it over to Scott to finish us out.
Thank you very much, Sharon. Next slide, please. So very quickly, so what's next for GetWell Loops and GetWell at LifeBridge? This next year, we're really focused on what we're calling hyper-personalization of the patient experience, especially in all the digital modalities that we have touch points with them. So there's three things that I thought were really good to kind of talk about that really are going to help us take this to the next level with those touch points. Recently, we upgraded our Cerner patient portal out of the old Millennium look and feel and design into their new Cerner consumer framework. And what that let us do is actually integrate their care plans into the patient portal dashboard so that when they log in to their LifeBridge Health patient portal, they're actually able to see where they are in their current care plans and do their updates as they see fit. And that's integrated into our mobile app. And that's actually kind of where we're going next is we want to expand the GetWell Loop capabilities directly into the LifeBridge Health mobile app. It's an app that we create ourselves. We have full control over it. And so we really want to take advantage of any APIs that GetWell offers to really kind of give patients the ability to not have to hunt and peck for different websites, for text messages, for emails, but really like put everything in one place in their hands for them. And then finally, as another part of this hyper-personalization effort and with a focus on trying to close care gaps, we are beginning to engage with all of our ambulatory faculty clinicians to roll out some standardized chronic condition loops through the entire service line so that if you go to a LifeBridge Health primary care physician, the same loops are going to be offered. Same thing if you go to an endocrinologist or into our ortho setting. And that's really it. That was our last slide, so thank you very much.
All right, thank you very much, Team LifeBridge. This is great information. And hopefully this was helpful to our VA partners who are getting ready to embark on their journey with GetWell Loop. They're really in the early stages, so I know this will be very helpful to them. So thank you for spending some time with us today and talking about your journey with GetWell Loop. Definitely helpful. I don't see any questions typed into the question panel, so I just want to verify really quick with the rest of the GetWell team on that I'm not missing anything in the platform before we wrap things up.
I don't see any, Carl.
Okay, awesome. So thanks again for our four presenters today. It's truly appreciative. I know it's very difficult to carve out an hour of everybody's time, in today's healthcare environment, we're doing more with less. So it's even though this work's very important, and I do appreciate your time. So with that being said, we're going to conclude the webinar for today. Like I had mentioned in the beginning, as soon as you close out the webinar platform, there's going to be a couple of questions that'll be asked of you. Please take, about 5 minutes and just complete those questions for us so that way we can better plan, for our next webinar, which should be happening in the late fall of this year. So thanks, everybody. Have a great end of your week.